Hi, I'm Anna Maria Sebastian.
And I'm Teresa Maria Sebastian,
Now,
students of Georgian College.
and our topic is nutrition therapy in gestational diabetes mellitus. An introduction to GDM or gestational diabetes mellitus. It is currently one of the most common complications occurs during pregnancy. It is a condition in which a hormone made by the placenta prevents the body from using insulin effectively. It results in high blood sugar level, that is diabetes. It is mainly observed in obese and overweight pregnant females and with females who has a family history of diabetes. It usually results after birth, but it arises shows some complications. That is large baby or macrosomia. That, as you can see in the picture, the baby is born with overweight or with some medical problems, high blood pressure, preeclampsia, a serious complication of pregnancy with high BP, and protein occurs in urine, swelling, headache, and blurred vision. Type and developing of type 2 diabetes after 10 years of giving birth is commonly seen, and sometimes reoccurring of GDM in future pregnancies also seen. The lifelong risk of obesity, metabolic syndrome, diabetes to the infant that is born is seen very commonly. The premature birth or stillbirth of a baby is also happens. Diet is recognized as an essential part of GDM management that can lead to improved pregnancy outcomes. Medical nutrition therapy for GDM aims to meet nutritional requirement of pregnancy for the birth of a healthy infant while maintaining the normal glycemia in order to reduce complications that are associated with GDM and meet the specific needs of the individual. Nutrition therapy for GDM include development of an eating pattern designed to lower glucose, blood pressure, and alter the lipid profiles. It also lower risk of CVD, coronary heart disease, and stroke. To ensure appropriate treatment, routine tests between 24 to 28 weeks of pregnancy is done. In high-risk women, testing begins to prior to pregnancy or soon after the conception is done for finding any hiding diabetes. Little history. Before World War II, that is discovery of insulin, extreme carbohydrate restriction diet was followed. That is with a high intake of fat, around 20% of fat, and restricting the carbohydrate to 8 to 9% of total energy requirement. After discovery of insulin, restricted carbohydrate diet maintained as a key component of therapy with including insulin in the therapy. By 1990, based on clinical experiences, it was recommended that calories be sufficient to avoid starvation ketosis, with carbohydrate restriction maintained at 30 to 40% of total calories versus the national guideline of recommended more than 50% of carbohydrate as energy requirement. This limited the postprandial hyperglycemia, low fetal glucose exposure, and lessened microsomia. However, in continued studies stated that glycemic control could be achieved using diet of less than 42% of energy as carbohydrate helped to avoid need of insulin therapy. Importantly, women with GDM who attained a fasting glucose less than 95 mg per dl within 2 weeks of diet alteration is less likely to require insulin or any kind of oral medication to control the GDM.
Gestational diabetes diet. For this, we have to in, in, uh, increase the intake of fruits and vegetables, fish and poultry, beans and legumes, nuts, seeds, whole grains, and increase the intake of fat-free and low-fat dairy products. Most importantly, avoid or limit saturated fat, coconut oil, palm oil, and sweets. Instead of it, it is highly recommended to use healthy oils such as virgin oil, olive oil, canola oil, etc. Dietary interventions of GDM diet includes intake plenty of whole fruits and vegetables, moderate amount of lean proteins and healthy fat, Moderate amount of whole grains such as bread, cereals, pasta, rice plus starchy vegetables like corn and peas. Limit food with high sugar such as soft drinks, fruit juice and pastries. Overall, it is important to focus on quality of carbohydrate and encourage consumption of vegetables, fruits, complex of carbohydrates and high fiber foods. Most importantly, it is recommended to have a good physical activity and exercises, um, and keeping adequate weight gain, and avoid smoking and unhealthy lifestyles. Other dietary interventions are, according to meta-analysis, women supplemented with 600 microgram of folic acid before pregnancy can reduce risk of GDM by about 30% than with no supplements. Probiotics during pregnancy can exogenous nutrient interventions reduce risk of diseases in GDM patients. But in this case also, it is not clear about overweight women. In some countries, alternate Mediterranean diet are also followed, which includes a lot of fruits and vegetables, also showed low incidence of GDM and better degree glucose tolerance. Other than this, some medications are also followed, like insulin injection, metformin, glibenclamide, and myoinsitol supplementation are also used in some countries. There is still no specific unified guidelines for nutrition therapy in GDM. Studies and researches are on still going on developing are on still developing stage. For example, in India, um, some countries are taking initiative for managing GDM. For example, in India, in 2016, Foxy initiated a certification called Manyada. It covered a quality of diagnosis, training of healthcare personnel about gestational diabetes mellitus treatment, nutrition, and data collection. And here are the references for the studies. And thank you all.